Dear students, today I would like to present my lecture, The Craniocerebral Trauma Part 1 for medical students. I am Andrii Sirko from Nervous Disease and Neurosurgery Department, Dnipropetrovsk Medical Academy. The craniocerebral trauma is the main cause for the disability and mortality among young people of age from 15 to 24 years. According to statistical data, men are injured by 2-3 times more often than women in all age groups. Over 50% of all cases of the CCT and 70% of lethal results in the CCT are the part of the car accidents. Falling from the height is the second main cause. In more than 50% of patients, there are multiple damages due to the severe CCT, which lead to the significant loss of blood, systemic hypertension, and hypoxia. For the last years, the CCT frequency in Ukraine fluctuates from 2.3 to 6%, about 200,000 cases a year. The pathophysiological changes occurring after the primary lesion of the brain lead to the secondary damages. Various factors such as the hypoxia, hypercapnia, and hypertension increase the expression of these changes. The treatment measures which are performed, taking into account the pathophysiological disturbances, considerably improve the course of the CCT. The intensive care in the CCT is to avoid the secondary brain damage. The brain is contained in the skull having the fixed volume. The intracranial pressure increases in the case when the volume of any component which contains in the skull, the cerebral cells, intracellular, extracellular liquid, cerebrospinal fluid and blood is enlarged. So, that action of compensatory mechanism is nullified. In norm, the ICP in people is less than 10 mm gidrargium. The intracranial structures are elastic. Therefore, rising of volume of the intracranial contents at first doesn't lead to significant growth of the ICP. However, there comes a moment when the compensatory mechanisms aren't able to cope with the volume increase anymore, and then even the slight increase of volume causes rising of the ICP. Rising of the ICP in the case of craniocerebral trauma can be caused by the hematoma, the brain edema, vasodilatation, and disturbances of process of absorption of the cerebrospinal fluid. The intracranial hypertension can cause two main pathological effects, the ischemia and brain herniation. Rising of ICP leads to the brain ischemia due to decrease of the cerebral perfusion pressure. The cerebral perfusion pressure is determined by subtracting from the value of average arterial pressure the value of ICP. The rising of ICP leads to depression of CPP, and when the volume of the last reaches the critical value, about 50 mm gidrargium, the brain ischemia develops. The decompensated cranial hypertension eventually leads to brain herniation. Brain herniation is a potentially deadly side effect of very high pressure within the skull that occurs when a part of the brain is squeezed across structures within the skull. The brain can shift across such structures as the falx cerebri, you can see here, the tentorium cerebelli, and even through the foramen magnum, the hole in the base of the skull through which the spinal cord connects with the brain. Herniation can be caused by a number of factors that cause a mass effects and increase intracranial pressure. These include traumatic brain injury, intracranial hemorrhage. The tentorium is extension of the dura mater that separates the cerebellum from cerebrum. There are two major classes of herniation: supratentorial herniation and infratentorial herniation. Uncal, transtentorial herniation. In uncal herniation, a common subtype of transtentorial herniation, innermost part of the temporal lobe, the uncus, can be squeezed so much that it moves towards the tentorium and puts pressure on the brain stem, most notably the midbrain. Tonsillar herniation. In tonsillar herniation, also called downward cerebellar herniation, transforaminal herniation, occurring, the cerebellar tonsils move downward through the foramen magnum, possibly causing compression of the lower brain stem and upper cervical spinal cord as they pass through the foramen. The brain swelling in the CCT has a vasogenic and cytotoxic origin. The trauma, sufficient on the force to cause a hemorrhage into the tissue, breaks the integrity of the hematoencephalic barrier and leads to the vasogenic edema, the transudation of the rich in protein liquid through the damaged vessel wall. It causes increase of the volume of the extracellular liquid. The cytotoxic edema results from the oxygen starvation of cells of the brain and is followed by accumulation of sodium and water inside the cell. The global and focal ischemia, plasma hyposmolarity, or lung hypoxia, these are the factors which separately or together may lead to the cytotoxic brain edema. Classification of craniocerebral trauma. A traumatic brain injury, TBI, also known as an intracranial injury, is an injury to the brain caused by external force. TBI can be classified by some mechanism: closed or penetrating head injury, severity, mild, moderate, severe. Mechanism-related classification divides TBI into closed and penetrating head injury. A closed, also called not penetrating or blunt, injury occurs when the brain is not exposed. A penetrating or open head injury occurs when an object pierces the skull and breaches the dura mater, the outermost membrane surrounding the brain. The assessment of level of consciousness is the leading factor for the diagnostics, determination of tactics of further treatment, and prognosis of results in patients with the craniocerebral trauma. The Glasgow Coma Scale, Graham Tisdale and Brian Jennett, 1974, allows estimating the level of consciousness on the basis of results of tests: opening the eyes, speech, answers, and motor functions. The possibly total number of points is 15. They evidenced about the severe CCT when for 6 hours and more the total counted number of points are 8 and less. The Glasgow Coma Scale gives the opportunity to consistently compare the amount of neurological damages from different patients and to predict the exit from a condition of the disturbed consciousness. Severity of craniocerebral trauma. Brain injuries can be classified into mild, moderate, and severe categories. The Glasgow Coma Scale, the most commonly used system for classifying TBI severity, grades a person's level of consciousness on a scale from 3 to 15 based on verbal, motor, and eye-opening reactions to stimuli. In general, it is agreed that a TBI with a Glasgow scale of 13 or above is mild, from 9 to 12 is moderate, and 8 or below is severe. It's a very important slide. A current model developed by the Department of Defense and Department of Veterans Affairs uses all three criteria of Glasgow scale after resuscitation, duration of post-traumatic amnesia, and loss of consciousness. Classification. There are two main types of injury according to pathological features. Focal injury, you can see in this slide, and diffuse brain injury, you can see here. Focal brain injuries often produce symptoms related to the functions of the damaged area. Research shows that the most common areas to have focal lesions in non-penetrating traumatic brain injury are the orbitofrontal cortex, the lower surface of the frontal lobes, and the anterior temporal lobes, areas that are involved in social behavior, emotion regulation, reflection, and decision making, and the common social, emotional, and judgment deficits follow moderate severe TBI. Symptoms such as hemiparesis or aphasia can also occur when less commonly affected areas such as motor or language areas are respectively damaged. Diffuse axonal injury. Diffuse injury manifests with little apparent damage in neuroimaging studies, but lesions can be seen with microscopic technique post-mortem, and the early 20th century researchers discovered that diffuse tensor imaging (DTI), a way of processing MRI images that shows white matter tracts, was an effective tool for displaying the extent of diffuse axonal injury. Types of injuries considered diffuse include edema, swelling, and diffuse axonal injury, which is widespread damage to axons including white matter tracts and projection to the cortex. Types of injuries considered diffuse include concussion and diffuse axonal injury, widespread damage to axons in areas including white matter and the cerebral hemispheres. The traumatic injuries of the brain are divided into the concussion, contusion of the mild, moderate, and severe degrees, and compression without contusion and due to contusion, and diffuse axonal injury and hand compression. You must remember then concussion and mild contusion, these two clinical forms of craniocerebral trauma, refers to or belongs to mild CCT, then moderate contusion and chronic and subacute compression belongs to moderate CCT, and then severe contusion, acute compression, and diffuse axonal injury refers to severe CCT. Summary. The closed craniocerebral trauma, closed brain injury, means such damages where disturbances of integrity of the integuments of the head are absent, or there are wounds of the soft tissue without damage of the aponeurosis. The open CCT includes all injuries with wounds of the soft tissues, which are accompanied by damage of the aponeurosis and fractures of the bones of the brain case, skull fracture in the area of pneumatic sinuses, or fracture of the base of the skull with the liquor on nature of integrity of the cerebral dura mater. The open CCT is subdivided into non-penetrating and penetrating fractures of the skull bones, which are followed by the efflux of the cerebral fluid liquor from a wound, ear or nose belong to penetrating. Close brain injury classification, two type: primary and secondary brain injury, divided into diffuse, focal, and next clinical form: concussion, contusion, diffuse axonal injury, laceration. And next factors for compression of the brain include epidural, subdural, intracerebral hematoma, and other. Dear students, thank you for your attention and see you soon in classroom.